If you have any technical difficulties during today's webinar, you can type into the chat feature and our team will try to assist you. There will be a chance for questions at the end of the webinar today. Please type your questions into the Q&A at the bottom of your screen and they will be addressed at the end of the slide presentation. Now it is my great pleasure to introduce our speaker today, Dr. Meera Chitlur. She is the Professor of Pediatrics at Central Michigan University College of Medicine and Barnhart-Lusher Hemostasis Research Endowed Chair at Wayne State University. She serves as the Director of the Hemophilia Treatment Center and the Jean M. Lusher Special Coagulation Laboratory at Children's Hospital of Michigan. Dr. Chitlur is an invited member of the National Hemophilia Foundation's Medical and Scientific Advisory Council, MASAC, and chair-elect of the Learning Action Network of the Women and Girls with Blood Disorders Foundation. Dr. Chitlur's clinical focus is on bleeding and thrombotic disorders in children with a special interest in girls with bleeding disorders. Dr. Chitlur?
Good afternoon, everyone. I'd like to start by thanking Sherry for her very nice introduction. And thank you, HFM, and everybody for inviting me to give you this talk today. Let me just share my screen. Give me a moment. So I hope everybody can see my slides. So thank you all for coming here this afternoon to spend an hour with us. And I hope that I can share information that will be very helpful to you. And if I don't have the information, I promise you can send me a question and we will find the information for you. So today we're going to talk about bleeding in women and girls with bleeding disorders. And as such, it's my great pleasure to say that I've had the opportunity to work with young women and girls who have bleeding disorders. I am a pediatric hematologist. I'm not an adult hematologist or a gynecologist, but I've had the opportunity to work with them as a part of our girls clinic at Children's Hospital of Michigan. So I hope that my experience with my patients over the last 10 years or so has allowed me to gather some expertise in this area, which I'm happy to share with you today. Okay. So the first question is always, what is the scope of the problem or what's the extent of the problem, right? It's very important for us to understand how many patients we have with bleeding disorders that are women in order for us to make sure that we address the problems appropriately and also to address the right audience. It's also important for us as providers and also for you as patients to understand that gynecologic bleeding may be the only presentation or symptom that you see in women with bleeding disorders. And I think this lack of awareness still exists in the medical community, unfortunately, both in the pediatric, gynecologic, as well as the obstetric fields. But I must say that the work of the Foundation for Women and Girls with Blood Disorders over the last 10 years or so has really made a difference in this area. And there are a lot more centers now that have specialized care for women and girls with blood disorders. And this has also raised the awareness in the gynecology field as well. So the next thing is for us to understand or realize what is the impact on the quality of life for our patients who have these bleeding disorders. Without that awareness, it's very difficult for us as providers to ensure that we are providing the type of care that's actually relevant to our patient population. And the next, but last but not the least at all, I want to say is the recognition that anemia is actually a symptom and not a disease. So treating anemia with iron does not fix the problem. It just fixes the anemia for a short time. So it's really important for you as a patient to realize that if I have a diagnosis of anemia, to ask the provider, why am I anemic? Okay, it's like taking Motrin for fever without treating the infection that's there if you just take the iron for the anemia. So I really want to make that point across to make sure that you all understand the importance of ensuring that anemia is addressed appropriately in this population, because that might be the one sign that they may be bleeding that you are unaware of. And so it's really important for us to recognize this. So if you look at it for the first point on the lack of estimate of the extent of the problem, right? We need to have numbers. Why do we need these numbers? In order to ensure that we are given the right resources or they can allocate right resources to take care of the problem. How do we get these numbers? Really, the only way we have at this point of time to understand what the numbers are for patients who have bleeding disorders is the numbers that are provided by the hemophilia treatment centers to databases such as Athens or CDC. Okay, so if you're not a patient at a hemophilia treatment center, you're probably not being counted as one of the patients who has a bleeding disorder. And that takes away from being able to get the numbers that are necessary to show what are the resources that are required. So it's extremely important, I would say, to encourage your friends who may not necessarily be seen at a hemophilia treatment center to actually seek care at a hemophilia treatment center in order for us to make sure that you are taken care of appropriately. I am not saying that the private hematologists are not good physicians. They may be excellent physicians. But at the same time, because of the type of resources that are allocated for you at a hemophilia treatment center, it would be to your benefit to be actually seen at a hemophilia treatment center. Okay, so this is actually a study that I just wanted to show that looked at patients who are on the Athens network, which is now the current database for monitoring patients with bleeding disorders. And they compared it to the female UDC, which was the CDC's collection of patients who had, or women who had bleeding disorders. What was very interesting to me in this paper is the proportion of patients and what kind of symptoms they reported. They looked at what were their symptoms, where did they get their care, and what kind of disorders did they have. So if you look at this graph, it's really interesting that the gray bar is actually the female UDC, and this is the Athens database network. And this was reported as a proportion, and I think that discrepancy is not necessarily that females on the UDC had more symptoms, but I think it had to do with the fact that there was only 300 patients here and there are 8,000 patients here. And the denominator might be a much larger number here compared to this, and therefore the proportions look very, very different. So the most common bleeding disorder that was reported in this study is heavy menstrual bleeding. Okay, and joint bleeding was also seen in many of these patients. But if you look at the proportion of patients who had joint bleeding, depending on the type of bleeding disorder that they had, it was still only about 8.6% of patients that had a bleeding disorder that reported joint bleeding. So while joint bleeding is an extremely important symptom that needs to be addressed and should be treated just like you would a male with a bleeding disorder having a joint bleed, I think it's also important for us to recognize that gynecologic bleeding can be a major bleeding issue in this female population and should be addressed and given equal importance. So recognition of the bleeding disorder, like I said, is extremely important. And I think it's extremely important to know that a large proportion of females who have bleeding disorders actually only report gynecologic bleeding, whereas all the other types of bleeding, such as mucocutaneous bleeding, joint bleeding, surgical bleeding, are seen, but not reported to the same extent. And because of the constraints of time today, I'm just going to focus on the gynecologic bleeding aspect. I'd be happy to address other issues if we have time over the Q&A. So let's talk about menstruation first. This has always been a taboo, and I hope it won't be, but as of now, nobody wants to talk about periods. Nobody wants to share information about their periods. This is not always treated as a bleeding issue. It is just considered a physiologic process that happens in a girl. It is physiologic, definitely, but I think it's important for us to recognize how much is physiologic and how much is not. Okay, so if you look at menstruation, it is the cyclic shedding of the uterine endometrium. This process starts at what we call menarche in medical terms, and the average age is about 13 years, although it can vary very widely, anywhere from 8 years all the way to 16 or 17 years. It lasts till about 51 years of age, which is the average age in the North American population, and that, as you all know, is menopause. The duration of flow normally is about 2 to 7 days, and the amount of flow is about 25 to 80 milliliters. So if you look at this, 25 milliliters is less than an ounce, and 80 milliliters is less than 3 ounces. It's very difficult to quantify 3 ounces on a pad, okay? So we'll talk about that in just a minute. But the average bleeding for a period should be about an ounce, which is 30 milliliters, which is not much. And this is not per day. This is for the entire duration of the period. It should be regular, usually month to month. This is what you usually see. So this is what a normal menstrual cycle should look like. Okay. So what is considered abnormal? And there are some medical definitions that exist. They used to be a little bit different before, and that's why I just decided I should bring this up here. So what used to be called menorrhagia, menometrorrhagia, dysfunctional uterine bleeding in the past, now in 2017, the American College of Obstetrics and Gynecology changed those definitions. They thought that this is actually easier for people to follow. So abnormal uterine bleeding is defined as a change in the usual menstrual pattern or volume, and heavy menstrual bleeding refers to heavy bleeding regardless of the frequency or the duration. Prolonged menstrual bleeding, on the other hand, refers to periods that last more than 8 days at a time. Intermenstrual bleeding, like the word says, is bleeding between periods. Abnormal frequency is a disturbance of frequency and cycles that are shorter than 21 days or longer than 36 days. And irregular menstrual bleeding refers to onset of menses that is unpredictable, which is you can't tell when you're going to have a period. It can happen anytime. So that's what irregular means, as the word says. So what can cause all these abnormalities in your bleeding? Okay. So we can look at this by age, because there are some things that might be more common at certain ages versus others. And it's important for us to remember this, because depending on the age of the patient, we might have to consider all these other issues in addition to having the bleeding disorder. So anovulatory bleeding is usually the problem that we see usually at the onset of menses, and it lasts for about 4 to 5 years. Typically, usually the first year or so, maximum 2 years, is supposed to be the period of anovulation. After that, it's supposed to regularize. And so depending on when you start your period, for the first couple of years, you may have irregular periods or heavy bleeding that is primarily related to what we call anovulatory bleeding. And I'll go over it just a little bit more in a minute. So bleeding disorders obviously can affect your period all the way from when you start your period to the time when you end your period. So from menarche to menopause, bleeding disorders can cause heavy menstrual bleeding across the age group. Having a local pathology like a fibroid or something that is what we call structural typically is seen in the older age group. We don't see that in the younger population. So we don't necessarily always do an ultrasound when you have heavy menstrual bleeding and you just started your period. Whereas if you are 30 or 35 years old and you're having heavy menstrual bleeding, we might want to actually do an ultrasound to make sure that there's nothing else that's causing your periods to be heavy. Having a systemic disease or something like hypothyroidism can also affect your periods and make them heavier, and therefore that's also important for us to recognize. Anticoagulant therapy or being on a blood thinner obviously can affect the bleeding. Although it's not that common, at least in the pediatric population, it doesn't seem to affect how much bleeding the patient has, irrespective of the fact that they're on blood thinners. But that is something that we have to keep in mind. It could be a complication of surgical interventions that the patient has undergone. Again, that would be more likely to happen in the older age group. Having low thyroid, like I said, is a systemic disease, and that can obviously affect you as well. Okay. And perimenopausal anovulation refers to anovulation that's occurring just before your menopause versus the anovulation that occurs when you just started your period. Okay. So what is abnormal? I think this is a very important aspect that we need to recognize. So what counts as heavy? Many times we tell patients, okay, is your period heavy? If that's the only period they've had, they don't know any different. So it's very difficult for them to quantify and tell you, oh, it's heavy. Because if you've had a lighter period, then you know what heavy is. But if the only period you've had is heavy, nobody's walking around talking to other people saying, how much do you soak your pad? Is that normal or abnormal for you to find out, right? So what counts as heavy? Bleeding more than 7 days is usually heavy, okay? And if you bleed more than 80 milliliters, or typically we count 100 as the cutoff, as milliliters of blood per cycle as being heavy. So how do you know you're bleeding more than 100? Nobody's squeezing that blood into a beaker to measure how much you're bleeding, right? So there could be other indirect evidence that this is actually a heavy period. Okay, if you're passing clots that are greater than 1 inch in diameter, which is typically about a grape size, a medium-sized grape size. So if that's bigger than that, that's heavy. If you're having to change a pad or tampon every hour, or if it's a student and you can't sit through your class without soaking through your product, then that's too much. So an average class duration here is about 45 to 60 minutes. So if you have to get up in the middle of the class to change, then you're bleeding too much. If you're frequently having to change your bed linen or underwear or clothing all the time because your hair is soaking through, or what we call flooding, then that's an issue. Obviously, if you have anemia that we think is directly related to having heavy periods, that's too heavy. If you stand up and your blood is falling down between your legs, then that's too much. Having to use more than one pad or tampon, many people will double up. They'll use a tampon and put a pad on, or use two pads. So those also indicate that you're bleeding more than you should. Some patients actually use adult incontinent briefs to manage heavy periods. That's again another indication that your period is too heavy. A good way to be able to accurately measure this is really to be able to measure this pictorially, or have a way to score it so that your physician can see it. They're not looking at your pads every day, but they need to be able to have a good way to quantify this bleeding. So we use what is called pictorial charts, which is the paper chart that you're seeing here on the left side, that you can get from your physicians, that you can do. Or this is now available as an app, which is called the Sisterhood, which I really, really like, because it's very convenient. It's very accurate in how it does it. And it actually gives me a score. The score here on top that you see, that score defines actually how much blood you're having, how much bleeding is happening. And that is very helpful as a physician for me to know exactly how much bleeding you're having. Okay, so that's important information for me to have to ensure that I'm accurately assessing how much bleeding you're having with your period. Sorry, give me a second. Okay, anovulatory bleeding was the first topic that we said, or first point at the onset of menses that can result in heavy menstrual bleeding. Okay, so our menstrual cycles are actually controlled by our brain, and the hypothalamus in the brain actually secretes a hormone that then asks the pituitary to secrete hormones, that then asks the ovaries to secrete estrogen and progesterone. And so that in turn will actually define how much of the lining we're building up in the uterus, and therefore how much bleeding we're going to have. In addition to the fact that these hormones actually define how much lining we're building in the uterus, it also makes maturation of the egg that is released happen, because that then defines whether we're going to keep that lining in place in order to support a baby, or we get rid of that lining because there is no baby there. Okay, so anovulatory bleeding essentially refers to the fact that there is no egg being released. Okay, because like I said before, the body initially is trying to learn. It hasn't figured out how to run these cycles of when estrogen needs to go up, when progesterone needs to go up, because the other hormones that either the pituitary or the brain are releasing are not necessarily cycling appropriately. And therefore, if you have no egg, then there is no development further down that cycle. And therefore, you end up with lining in the uterus that is built up excessively, and it becomes sort of unstable over time, and then you shed it. And so it ends up with a lot of lining usually, and therefore a lot of bleeding, and also can be quite irregular. So that's what anovulatory bleeding refers to. And having anovulatory bleeding does not necessarily mean that you don't have a bleeding disorder. So it's important for patients who present with bleeding at the start of their cycle to still get evaluated for a bleeding disorder, to make sure that we're not missing something like that. Okay. So coming then to what kind of bleeding disorders actually present with heavy menstrual bleeding. So the most common bleeding disorder that we see is von Willebrand's disease. In the Caucasian population, the number of patients with von Willebrand's is 1%. The incidence is 1%, which means 1 in every 100 patients has one in every 100 people has von Willebrand's disease. Okay, but the incidence of heavy menstrual bleeding was actually much more common in those who have problems with their platelets rather than just von Willebrand's disease. So that I thought is an interesting point. So while we have more patients with von Willebrand's disease, the incidence of heavy menstrual bleeding is much more common in those who have platelet problems. Okay. Coming to management choices. Okay. So when we take care of a patient, I think we have to look at certain factors which are patient-driven, as I call it, and certain factors which are physician-driven. Okay, and both of them have to be given equal importance, because there are some things that are necessarily important for the patient, and therefore the physician has to take those into consideration. And on the other hand, there are certain things that are very important for the physician to ensure that the patient is appropriately taken care of. Okay, so severity of the disease, what kind of lifestyle this patient is maintaining, what kind of activity this patient is involved in, and what is the access of care? How far do you live from your center? What kind of insurance do you have? How does the insurance define what care you get? All of those are important things, unfortunately, that we do have to take care of and be aware of. From a physician perspective, what kind of product you need will depend on how and what I am treating, right? So am I trying to prevent a bleed? Am I trying to treat a bleed? Okay, how long are you going to require this treatment? Okay, what kind of bleeding are we looking at? Is it a joint bleed? Is it menstrual bleeding? So that will also define what kind of products I want to think about that might be helpful for you to manage your bleeding. Okay, so I thought it would be helpful to look at a couple cases, and I apologize up front. Both cases are technically von Willebrand's, but I will expand it to say if you had other bleeding disorders how we could tailor that. Okay, so this is an 18-year-old who has type 1 von Willebrand's disease and heavy menstrual bleeding. She started her period when she was 12, so she's had this now for 6 years, and she comes to the hospital or emergency room primarily because she's got headache and dizziness, and her periods are usually 10 days or longer. I'm so glad the emergency room physician asked that question, and she's been bleeding now heavily for the last 6 days, and she's changing her pad every hour, and she's passing large clots. She's also very tired and sleepy. So in the emergency room, the physician checks her blood count, it's 8.6, and the physician orders an ultrasound because when she examines her belly, there's some pain, and therefore she wants to make sure that everything's okay. But then unfortunately, they find a large hemorrhagic ovarian cyst, which is unfortunately not a very uncommon problem when you have heavy periods and heavy bleeding and a bleeding disorder. Okay, so in this case, we have a couple of problems. One is you have an ovarian cyst, and then you have a bleeding disorder. Okay, so the ovarian cyst could be because you have endometriosis, or it could be other benign tumor. What are the other options, or you have to think about when you see an ovarian cyst? That's what that's referring to. Okay, and from a bleeding disorder perspective, of course, any of these bleeding disorders can result in heavy menstrual bleeding. Okay, so when I'm thinking about how I treat this patient, okay, one thing would be to correct the bleeding disorder. Now this patient is actively bleeding. She's having a period. It's been there for 6 days already. She's heavily bleeding to the point where she's actually in the emergency room, anemic and symptomatic. So in this situation, I want to stop the bleeding right away. Okay, so what do I know about what's the best way to stop the bleeding? One way is to increase or change the factor deficiency. So if you have von Willebrand deficiency, you give von Willebrand factor. If you have hemophilia, you give factor 8 or factor 9 or whatever product you're missing. If you have other bleeding disorders, we'll have to look at it. If you have a platelet dysfunction, you might need platelets. If you have other factor deficiencies, we have to see if there's a product available for you, or if not, maybe provide plasma to replace the factor that you're missing in order to stop the bleeding. Okay. If you're not actively bleeding, but you're anemic because you have already bled, then maybe we need to think about in the future, what could we do to manage this bleeding or to prevent you from having any more periods for at least a short time? Maybe that's the way to go. So in this situation, we might need to use what is called an antifibrinolytic, or we might have to institute some hormonal therapies in order to take care of the bleeding. Okay. So coming to the hemorrhagic ovarian cyst, the important thing about this ovarian cyst is that it's important to prevent it from happening again, because that's important to protect your fertility. Okay. And the only way we can prevent it really from happening over and over again is to keep you on a combined hormonal contraceptive. And this is available either as a pill or a patch or a vaginal ring. Okay. Unfortunately, progesterone only pills are not very effective because they don't suppress ovulation. Neither does an IUD because it doesn't suppress ovulation. It's effective to control bleeding, as is progesterone, but not effective in preventing hemorrhagic ovarian cyst from happening again. Now coming to the heavy period bleeding, okay, based on the age of the patient and the need for maintaining fertility, you will make your decision on what kind of testing you need to do. Or what kind of management you need to do. It's also important to remember that just because you have a bleeding disorder does not mean you could not have another reason for the bleeding, okay? So it is important for you to check and make sure that there's nothing else wrong that would be causing bleeding. Endometrial abnormalities are very common, and in the younger age group, this is something that you want to make sure that you've tested and ruled out, even though, you know, at least to make sure that you've documented that it's negative. So many times when we do the testing, it insults patients that we're thinking you might have chlamydia or gonorrhea. That's not the point. The point is that if you actually have an infection and I don't treat it, it's not going to help your bleeding. And therefore, it's important for me to check and say you don't have it, and therefore I don't need to consider treatment for this, okay? It's also important if you're an adult and if you're over the age of 40 or 50, that you do not have any other risk factors that could cause other problems, such as excessive blood clotting, by the treatment that I'm going to give to you. So it's really important for you to look at the age group to define what kind of treatment would be best for you. The first line of treatment for heavy menstrual bleeding is always hormones, okay? And there are several studies that have shown that the combined hormonal pills are very effective. And unfortunately, because this patient has a hemorrhagic ovarian cyst, an IUD or antifibrinolytics such as Lystida will not be effective in this situation. But if you do not have the ovarian cyst, then you could potentially use an IUD or Lystida to help take care of the blood loss, because you don't have anything else to worry about. So, but in this situation, the best option is the combined hormonal contraceptive for this patient. So again, this is just a chart that shows the same thing that I said in words. So you have to know whether this patient is old enough that you want to still preserve fertility or not. And you may consider surgical options for somebody who's older, who does not really need to take, we don't need to consider preserving fertility in that situation, okay? Now you have a 25-year-old, this is case number 2, 25-year-old who has von Willebrand's disease, who's on birth control to take care of her periods, but wants to get pregnant now. This could be any bleeding disorder, who's on a birth control pill, who wants to get pregnant, okay? So here, it is important for us to know that this is multidisciplinary care. That's very, very important, okay? If you want to get pregnant, you need the hematologist to help you get pregnant. But then once you're pregnant, you need a high-risk OB to take care of this pregnancy and make sure that delivery is appropriate, okay? You also need a pediatric hematologist who will assist with management of the baby after the baby is born, okay? It is important to discuss the genetics of the bleeding disorder. For example, if you have type 1 von Willebrand's disease, there's a 50-50 chance that your child will have it. If you're a female and you're a carrier, then there's a 50-50 chance that you will have a son with hemophilia or a daughter who's a carrier. So it's important for you to discuss these genetics with your doctor, so you know before you become pregnant what you're in for, okay, and how you want to deal with it. And especially because it's not just you, it's also your partner or your spouse that is going to be involved in this care. And it's really important for both of you to understand this. So there are mother issues and baby issues, and both of these have to be addressed appropriately, okay? Since I'm a pediatrician, I'm going to start with baby issues, okay? From a baby issues, it's really important for us to make sure that this baby does not have a bleeding disorder. So when I get a pregnant mom who comes in for counseling to see me, which happens quite often, unfortunately, is that we want to make sure that the mom understands what the genetics are and what is the likelihood that she's going to have a child with a bleeding disorder. And if there is a possibility that her child can have a bleeding disorder, then we actually provide them with information as to how we want to collect blood so that we can make sure the child is tested. We also want to connect with the obstetrician to make sure that they understand that they could have this patient can have a child with a bleeding disorder. And therefore, we do not want them to use any invasive procedures, as we call it. We don't want them to use a forceps. We don't want them to do any vacuum extraction, because that could increase the risk of the child or baby having intracranial hemorrhage. We also want to be able to get cord blood so that we can test the baby for the bleeding disorder, so that we don't have to poke the baby. That's most of the time it is possible. It's useful for hemophilia and factor deficiencies, but may or may not be useful for von Willebrand's disease, because at the time of birth, sometimes von Willebrand levels are very high, and therefore you may miss the diagnosis. So if the levels come back low, it's helpful, but if it comes back normal, then you might have to repeat it again in a few months. And I think the most important point to remember is just because you're a carrier of hemophilia does not mean a baby girl cannot have hemophilia. The baby girl can have hemophilia, so do not forget that. Okay, and circumcision is something that we might need to postpone if this is a boy, and therefore we want to make sure that those are important pieces of information that your gynecologist or obstetrician has, so that they can manage the baby appropriately. From a mom perspective, okay, so she has heavy menstrual bleeding, but she wants to get pregnant. So we can't let her become excessively anemic and bleed terribly before she gets pregnant. We want to keep that from happening. So we may have to use a different modality other than the hormones, because now you want to get pregnant. So the options might be that you use something like Amicar or Lystida in order to prevent the heavy periods until you get pregnant, okay? Then we could also use factor replacement. It could be von Willebrand factor concentrate or factor concentrate. It could be DDAP or stimate, depending on what kind of bleeding disorder you have. Then once you get pregnant, so the levels sometimes, depending on what kind of bleeding disorder you have, some of these levels might rise, okay? If you have hemophilia A, if you're a carrier of hemophilia A or have hemophilia A, your factor VIII levels may rise. If depending on your mutation, depending on your severity, they may not rise. So, but we need to know if the levels have risen, and we need to know if you do require treatment or not. So that's something that needs to be followed during the pregnancy. Okay. At the time of delivery, you must be managed at a high-risk center with a maternal fetal medicine consult. Okay. You must be co-managed with a hematologist who knows what to do with the mom who has a bleeding disorder. Levels must be checked during each of the trimesters, especially for von Willebrand's and hemophilia. Okay. Other factor deficiencies, it may not matter because it may not change. It may be the same. And so then, but still you need to be managed to make sure that you don't have any issues with maintaining the pregnancy or at the time of delivery. So what is the safety of epidural analgesia? I hate it when people call me to say that I have a mom who's dilated and is about to deliver a baby. Can I give her an epidural? I have no idea. There's no way for me to tell the obstetrician at that point whether it is safe to give the mom an epidural. You have to make sure that these levels, your factor levels, are checked before the delivery so that we can see if it is safe for you to get an epidural. Or you might be stuck by not getting an epidural just because we didn't check. Okay, so we might have to give you an infusion of a factor concentrate or a platelet transfusion so that we can make it safe for your epidural to be given. Okay, but if I don't have that information, I cannot help you there. Postpartum, again, some of these levels that rise fall again after you're done with the delivery. So we need to know, follow those levels, see when you need to get factor again or be treated again in order to prevent postpartum hemorrhage. And what kind of treatment is this going to be? Is it going to be factor? Is this going to be Lystida? Is this going to be something else? Okay. We do not want you to get NSAIDs because we don't want you to bleed. Or that's NSAIDs refers to Motrin and ibuprofen. Okay, especially in patients with von Willebrand's disease, the levels drop very rapidly in the first week or so after the delivery, and therefore you might need additional care at that point, and it's important to prevent postpartum hemorrhage. Okay, so we talked about the onset of the periods, and we talked about somebody who wants to be pregnant. Now we'll talk about somebody who's in the menopausal age, okay? So now we have a 51-year-old with type 1 von Willebrand's disease, and they have heavy menstrual bleeding. So this is what we call perimenopausal bleeding. It's around the onset of menopause, and like I said, the average age is about 51 years of age here. The funny thing is that it's sort of a mirror image of adolescence. Just like when you started out and you had irregular periods and heavy bleeding, now you can do the same thing just before you end. You can have irregular periods and heavy bleeding, okay? It can vary in the age of onset, the duration, what kind of bleeding you have, okay? But in this situation, it is still important for us to make sure that nothing other than your bleeding disorder is causing these bleeding abnormalities, okay? In this age group, you also have to remember that cancer is something that we need to rule out as a cause of the heavy menstrual bleeding. Other reasons may be much more important to make sure that you don't have in order to make sure that you're taken care of appropriately. Structural causes are also much more important, much more common in this age group, and therefore need to be looked at, okay? And iatrogenic causes, that means, are we doing something? Are we giving you a blood thinner because you're 51 and you had a heart attack or you had a stroke and that's why you're bleeding? So it's important for us to look at all of these things, okay? So in the perimenopausal age group, the bleeding occurs because the ovarian function declines. Just like before you were not ovulating, now again, you're not ovulating again, okay? So you may have short cycles, you may have long cycles, you may have really long periods. So it's important to go see a physician for them to do the necessary tests to make sure before they start something on you. Okay, so how do you take care of this? I think several of you had asked this question, and that's why I thought it was important. And I must acknowledge Dr. Andrew James and Dr. Kulkarni for their help with this, because obviously this is not a patient population that I take care of. So I had to ask them all these questions and make sure I'm giving you the right information, okay? So in this age group, I'm told hormonal management is the best, and low-dose estrogen are the preferred way to go, okay? It's much safer and has been found to be effective. In those who have cardiovascular disease, that means, any kind of heart problems, estrogens may actually increase your risk of having another cardiovascular problem, and therefore that may not be an option for you. In those situations, you may have to use an IUD in order to make sure that we don't give you too many estrogens or increase the risk of problems. But if you're having hot flashes or other issues with menopause, then maybe a much smaller dose of estrogen added to an IUD may be a good way to take care of both these problems. It is also important that you manage your cardiovascular disease appropriately. You see your physician, monitor your blood pressure. After the start of hormonal therapy, make sure that's monitored again to make sure it hasn't gone up. And we don't want to give you other problems by taking care of the bleeding problem itself, okay? It's also important to make sure that they do a biopsy if necessary to make sure that there's no endometrial atypia, as we call it, or precancerous lesions, because that would be important to take care of in a very different way. So if there is no atypia, as they call it, we could consider cyclic medroxyprogesterone acetate. We could consider Megace, we could consider an IUD, but then we would have to repeat the biopsy every 3 to 6 months to make sure that nothing has changed there. Surgical interventions like ablation, DNC, hysterectomy may be an option in this age group because you're not thinking about having any more children at that point, okay? Bleeding disorder specific management is also important, right? You can use Lystera maybe, but then you may need to get factor replacement. If you're thinking of surgical options, you have to make sure that the hematologist is aware and they're planning the surgery with your gynecologist, okay? So hormonal therapy is very helpful for management of sleep issues, hot flashes that are associated with perimenopausal symptoms, and transdermal estriol apparently has been found to be very useful for hot flashes without affecting your blood pressure. So for cardiovascular disease, that may be an option. This was a question that a couple of people asked, and so I thought, let me see what I can find. There's not much information about this. There's a couple studies that have been published, and none of them have talked about a bleeding disorder at all. But I just thought it is good for us to know what are all the causes for postcoital bleeding that you see, okay? And they could be endometriosis, it could be cancer, it could be polyps, chlamydia, cervicitis, any kind of inflammation in that area. So depending on the age of the patient, the etiology might differ. Okay, and so it's important to make sure that you've ruled out other causes of this bleeding and then take into consideration that it might be a bleeding disorder. Most of the bleeding is reported to be relatively mild, and so in my mind, I'm thinking this could be treated as a minor bleed that you would take care of with your bleeding disorder. Whether it would require just something like Amica or Lystera, or it would actually require factor replacement, depends on the severity of your bleeding disorder, and that would be something that you need to discuss with your hematologist specifically. So dysmenorrhea was the other question, or painful periods was the other question that you guys asked me to talk about. Okay, so this is another area that, the causes of dysmenorrhea are quite variable, and it could be anywhere from hormonal issues to endometriosis to other structural issues that are causing your painful periods, okay? And the treatment of this will obviously depend upon finding the etiology of these pain and then making sure you address that issue itself, okay? But the various options we have to take care of painful periods. One is non-hormonal therapy. Things like Tylenol and ibuprofen have been found to be effective, okay? Tylenol works in this situation by just increasing your pain threshold. The advantage of Tylenol is that it is tolerated well. You don't have any issues with ulcers and things like that. It doesn't inhibit any problems. It doesn't cause any problems with patients who already have a bleeding disorder. And it can be used with and without caffeine or diuretics, and that has been found to be much more effective in managing the painful periods or dysmenorrhea, okay? NSAIDs, on the other hand, are Motrin and ibuprofen. The problem is that we tell patients with bleeding disorders not to use this drug, okay? But actually, they work much better in managing pain because they inhibit the enzymes that actually cause the problem that causes pain and with periods, okay? So sometimes, as a hematologist, what I do is that I combine the use of Motrin or ibuprofen with something else and see if they can still manage without causing heavy periods, okay? So this is something that you would have to talk to your hematologist about. You definitely don't want to do this without talking to them. None of what I said today, I want you to take home and do without talking to your doctor, please, okay? Because I think it's very important to know the severity of your bleeding disorder and what might be okay for one person might not be okay for another person, okay? Hormones are another option because they can suppress ovulation, and ovulation is one of those things that causes the release of further hormones and enzymes that actually cause painful bleeding. So if we can suppress ovulation, that can also work. And by suppressing ovulation by using combined oral contraceptive pills, we can prevent heavy menstrual bleeding and also prevent the pain that's associated with the periods. Okay, Depo-Provera is found to be very effective when endometriosis is causing the pain, but can still be tried. IUDs are very effective and have been shown to be quite helpful both for suppressing ovulation and also to help with the pain. Okay. There are several alternative therapies that have been used for the management of dysmenorrhea. Exercise has been found to actually be effective, and both in randomized controlled trials as well as observational studies. TENS, which is the use of high frequency stimulation, frequency electrical stimulation of the skin, is found to be helpful. It desensitizes the skin apparently. The low frequency has not been found to be useful, but the high frequency has been found to be useful. But there's not very good studies that can say for sure it helps, but there are some side effects to this therapy, such as muscle tightness, headaches, nausea, redness of skin, skin burns, so be careful. Acupuncture, acupressure, again, inconsistent results. Behavioral interventions have been found to be helpful. I think these are some of those therapies that have been studied rigorously, so it's very difficult for us to say if it helps. But this is definitely something that's not going to hurt you to try. So to try relaxation training, try Lamaze exercises, try biofeedback is not going to hurt you in any way. So you could definitely try that to see if it works for you. Topical heat has been found to be useful, better than they said, actually, even the use of ibuprofen, but sometimes it's better when it's used with ibuprofen or exercise rather than by itself. But again, something that you can try. Dietary supplements have been studied, but not again rigorously, but these are all the different things that they've tried and some people have found to be useful. Now, if you're old enough, again, if these painful periods are around your perimenopausal age group, then you might want to consider surgical options, because if you don't need that uterus and there is no other risk to removing your uterus, that may be something to be considered. There are other things like pelvic denervation that have been studied, and this has been shown to be effective for endometriosis. Again, needs to be talked to with your gynecologist specifically. Okay. Thank you very much. I hope that information was useful to you. Keep safe. These are crazy times, but I hope we all come out of it in great shape. I will stop sharing my screen now. There you go.
Thank you, Dr. Chitlur. So we don't have any questions that have been typed in yet, but I'd like to give everybody a minute or two if they would like to ask a question to type it into the Q&A, and we will see if we can get an answer for you. So we will give that just a minute or two. I thought of something earlier. I should have typed it into the Q&A myself. Okay, we have a question. It says, when you have sex for the first time, how do you know what is a normal amount of bleeding?
Okay, that's a good question. What I would say is that it has to be minimal. It cannot be anything more than minimal. Anything more than minimal bleeding should be considered as abnormal, in the sense that if it is a bleeding that is persistent, okay, if it happens just at the time and it stops right after, then there's nothing to worry about. But if it continues to happen over the next hour or more, then it would definitely be abnormal. It's not something that is supposed to be present continuously. It is supposed to happen at the time and then stop right away. So I would say that anything that's beyond that instantaneous bleed is abnormal.
Thank you. Any other questions? Again, you can type into the Q&A if you have a question.
I want to say hi to Amar. I see one of my patients is online, and she said hi to me. Hi, Amar.
Here is another question. It says, you stated that the Athens study had joint bleeds reported at 8%. Could that number be artificially low because many women don't recognize mild bleeding episodes?
Excellent question and very important point. That's true. If women did not recognize that this is a joint bleed, if they think this is arthritis, there's no way for us to know. right? That's where the data collection becomes extremely important. And that's where going to a physician who's going to recognize this as a bleed, as a joint bleed, becomes extremely important. Okay. So being at a center where people are aware that women can have joint bleeds is essential for that to be recognized as a joint bleed. Okay. So being, I think that's where, that's a very important point, that yes, this could be extremely low because we just don't know. But there's no way for me to tell you what the actual number is unless we get everybody on board so that we can know that what's the right incidence of joint bleeds. What we have reported are obviously from patients who know what a joint bleed feels like and looks like. So
Thank you. It is interesting on that, even having a brother and two sons with hemophilia. I have had some joint issues and still been unsure. So I think, training people with a mild bleeding
yeah.
disorder is probably pretty important. All
And I
right, we've
think
got,
one more thing, Sherry, I would like to make a point. I think now one of the issues also is that, if you don't see a physician right away at the time of the joint bleed, they may not have the opportunity to even know that you've had a joint bleed, right? Unless you go right away. And maybe having these new tools like the point of care ultrasound, hopefully will improve the care in this manner, on this subject, because if there's a way for the physician to look at it right away and see if there's a bleed or not, that would be much more helpful. Because if you make an ultrasound appointment 4 days from the time you had the bleed, you may not see anything there anymore. So having point of care tools may actually improve our ability to make this diagnosis on time.
That's an excellent point. We have a couple more questions. This one says, I have VWD2B. I am
Mhm.
64 years old. Is it unusual that I still get bruising? I was diagnosed around age 30.
So, no, it depends on the severity of your disease. So, depending on how severe your disease is, it may be possible that your levels did not actually change very much, even though you're older. I know we believe that as you get older in patients who have von Willebrand's disease, it is possible that those levels go up to a point where your disease severity might decrease. But unfortunately, in patients who have type 2 von Willebrand's, because they secrete, even though their actual amount that they secrete changes, what they secrete is still abnormal. And so it doesn't help that your levels go up, because your levels, that protein doesn't work right. So I am not surprised that you still bruise. And in addition, you have to remember that as you get older, your skin changes too. And so you may bruise easier because of connective tissue issues as well as you get older. So the combination of having type 2B von Willebrand's disease plus the connective tissue issues may actually keep your bleeding symptoms the same in terms of bruising, at least.
Thank you. Here's another question. Might you have a bleeding disorder if your periods are not heavy, as you talked about, but are somewhat heavy in the first few days? Maybe going through 5 pads a day for the first 3 days and then it tapers off.
Yes, the duration of bleeding does not define heavy menstrual bleeding. I think if you remembered my definition, heavy menstrual bleeding, irrespective of the duration of bleeding, can still be heavy. So you can have a period only for 5 days, which is completely normal in terms of duration, but the amount of bleeding during those 5 days will define whether this is heavy or not. There comes the importance of following the amount of bleeding on your PBAC, on that sisterhood app, so that we can know how much you're bleeding during those 5 days.
Great, thank you. What if you were never tested and did have heavy, painful, horrible periods, then had one child with hemophilia A? I am full menopausal now, and I did have to have an ablation done.
Interesting. So you were never tested. You have one child with hemophilia A. I'm assuming you don't have a family history. Is that right? So if you don't have a family history, I think the only way for you to know is to get genetic testing done, whether you have a bleeding disorder or not. Okay. Because your factor levels alone may or may not be very helpful. Factor levels are important in this situation, but we know, unfortunately, that in the carrier population, your levels on the higher side may still be associated with bleeding. We have carriers between 45 and 60% factor 8. still having bleeding symptoms, although 60% is actually in the low normal range for people with, for factor VIII. So genetic testing in combination with factor levels might be an answer. The other point to remember is it is possible that you could have a different bleeding disorder. You may have a son with hemophilia A, but is it possible that you could have something else? I think that needs to be investigated as well. Okay. We used to feel that everybody has to have one problem and one problem alone. And unfortunately, we realize now that that's not always true. You can have patients with more than one bleeding disorder. We have quite a few patients who have von Willebrand's and hemophilia. So is it possible that your son can have hemophilia and you have von Willebrand's? It's quite possible. So I think you need to see somebody about this to be able to get the testing done in order to make sure that, you don't have some other problem.
Thank you for that good advice. We have we have two more questions. So I have 3 brothers and live with my dad, and it makes it a struggle for them to believe me in terms of how painful my symptoms are. They think that I am being overdramatic. How would I get them to get out of this stigma of emotional pain versus physical pain in terms of my period?
So I think in terms of your period, if your periods are heavy, it's not just emotional, it is physical. Okay. It is important for you to address the fact that you have heavy periods. So emotional pain needs to be addressed. I'm not discouraging you on that, but I think it's important for you to also know that you could physically be having a problem and which needs to be addressed as well. If you're anemic, that means it's not just emotional, it's also physical. And that could be because you're having heavy periods and that needs to be addressed. Okay. And having painful, heavy periods does not necessarily only need to be addressed if you have a bleeding disorder. It needs to be addressed, period. Okay, so you need to see a gynecologist to take care of your periods, whether or not you have a bleeding disorder. If you have a bleeding disorder, that puts in additional, things that you need to take into consideration when you're addressing the bleeding. But that doesn't mean that having heavy periods is okay if you don't have a bleeding disorder. No, it's not. That needs to be addressed irrespective of what kind of bleeding disorder you have or you don't have. Okay, so my advice to you is to see a gynecologist who will actually assess you for your periods to determine if there is an organic basis for your bleeding. And if so, that needs to be addressed. Okay, and from the emotional perspective of being a carrier and having to deal with those issues of hemophilia, I know that is something that we haven't, I think, addressed adequately in our carrier population. We do not have the kind of support groups that are, I think, necessary for you guys to connect, to be able to talk to somebody who is just like you, that is experiencing problems just like you, that you can connect with. I don't know what to say about increasing awareness in your family is important, that you could have a bleeding disorder, that you could have bleeding symptoms. I think that's essential. And that may have to come from their physician. Okay. Or if you share a hematologist, that may have to come from that hematologist to say that, your daughter or your sister can have bleeding because she's also a carrier and she could have bleeding even though she's just a carrier. Okay, so I think those are issues that need to be addressed from that point. And I think finding a support group, finding other people that could potentially you can connect with is very important here. Okay, maybe HFM could address that issue.
Thank you, Dr. Chitlur. Here is another question. When is the best time to make an appointment to get accurate factor levels if I have sporadic bleeding all month?
You should not have sporadic bleeding all month. And so that in itself tells me that it needs to be assessed, right? So if you're having sporadic bleeding all month and you're talking about factor levels for von Willebrand's or factor VIII, is that what you're talking about? I'm assuming that's what it is. I would anticipate that if the sporadic bleeding is occurring because of your factor levels, then it shouldn't matter when you do it. But the important thing to remember about irregular bleeding is that your bleeding disorder does not cause you to have more periods. It just causes your bleeding with each period to be prolonged. Okay? So irregular bleeding is hormonally related. but the amount of bleeding you have with each of those bleeding episodes is related to your bleeding disorder. Okay, so this is sort of two problems. You have to address the fact that your hormones are all over the place, and that's why you're having so many periods. And then you have to address the fact that your bleeding with each of those is terrible. So you would have to actually go in. You're the ideal patient in my mind that requires hormones to control the bleeding.
Okay, we have 2 more questions and then we're going to cut it off there. So if people have more questions, you can email me at slucky@hfmich.org. And let's do the last 2 questions. How do we remove the stigma of being overdramatic during our periods within the household? They don't believe me sometimes in terms of how painful my period is. I know it's sort of similar to the previous question.
Yeah. Okay, how about we start this way? How about we address the fact that your period, you need help to manage your period, rather than just try to say that, you know, they just need to deal with me when I'm having a painful period. I think we need to address the fact that you need help with your period and you shouldn't have that much pain with your period. Why don't we take away the pain rather than just try to manage the pain? Okay, so I think it's important. I'm not saying that we have a solution for everything, okay, but I think you need to see a physician to see if there's a way to manage the pain rather than just ask everybody else to manage us with the pain. Okay.
All right, and final question, who should we go to get these tests done? Should we start with our primary doctor or our OB to get genetic testing?
Uh, so genetic testing is best done by, if you're thinking about diagnosing your bleeding disorder, it's probably best done either your primary care physician, but then your primary care physician needs to know enough about the bleeding disorder in order for them to be able to know what kind of testing needs to be done. In my mind, the best person would be a hematologist. And if you are a person that potentially could have a bleeding disorder or has a bleeding disorder and you want to get genetic testing done, I think you should see a hematologist. That would be the best person who knows where and who should do those tests.
Thank you, Dr. Chitlur. Again, if you did not get your question answered, you can email me at sluckey@hfmich.org, and I will get those questions to Dr. Chitlur. I want to thank you so much, Dr. Chitlur. We appreciate your expertise today. I also want to thank Sarah Precario for running the webinar and taking care of any technical issues that were going on. Finally, I want to thank you so much for attending, and I hope that you will join us for our next Women's Luncheon, which is July 27th at noon. Thank you.
Thank you.